Hi everyone, thank you for joining us. My name is Mary Ambach and I will be presenting on hip ultrasound, advancing diagnosis using musculoskeletal ultrasound, and also to help with interventional procedures. First, I want to thank AMSKU, Colin and Ryan for including me in this conference. So my presentation will be divided on the regions, anteriorly, medially, laterally, and posteriorly. So anteriorly, we will go over the femorostabular joint or your hip joint, the labrum, the iliopsoas muscle tendon, and the rectus femoris tendon. Medially, the adductor muscles and tendon. Laterally, trochanteric bursa and the gluteal tendons. And posteriorly, we'll be going over the piriformis muscle, the hamstring tendon, and the SI joint. So why do I need to learn ultrasound-guided hip joint injections? This is a systematic review and meta-analysis of 439 hip joints. This is 9 studies that were included wherein they showed that the accuracy of ultrasound-guided injections is 100%, or at least almost 100%, versus landmark-guided injections with an average of 72%. They also found that the ultrasound was more convenient and that it was found less painful and more preferred by the patients. So let's go over a brief anatomy review. Most of you know that the hip joint is a ball and socket synovial joint, and this is formed by the femoral head and the acetabulum. Let's go over the important bony attachments of the tendons. So let's start with the AIIS, or the anterior inferior iliac spine, and this is the origin of the direct head of the rectus femoris. The labrum is this fibrocartilaginous material that surrounds the acetabulum, and it basically makes the hip more stable by creating a rubber seal around the hip joint. The greater trochanter is this lateral protuberance in the femur that acts as the attachment of your gluteal tendons. The lesser trochanter on the other side of the femur is the attachment of your iliopsoas tendons. And the intertrochanteric line connects the two, and this is where your capsule goes over, and you'll see it in the subsequent slides, attaches to here to fold over back into the femoral head and neck region. Next is the symphysis pubis, which is the origin of the adductor tendons. And then lastly, the ischial tuberosity here, which is the attachment of the hamstring tendons. So when you look at the hip joint capsule, it actually extends from the acetabulum all the way down to the intertrochanteric line. And then it folds back from this point on and folds back upon itself, and it inserts into the femoral head and neck junction. So if you look at the lower right part of your screen, you'll see an ultrasound image of your anterior hip joint, and you'll see a hyperechoic line anterior to the bony contour of the femoral head and neck. And this is your capsule, your hyperechoic capsule, extending all the way down to the intertrochanteric line before it folds back. Know that there are several capsular ligaments that surrounds your hip joint, and this is also to help create more stability in your hip joint. So this is the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament, and these are ligaments that extends from the ilium, the ischium, and the pubis respectively to insert to the femoral head and neck region. So when you're evaluating the anterior hip joint, a curved transducer is typically used, and this is a lower frequency probe that has a better beam penetration, so it's better for deeper structures like the hip joint. You're going to position this transducer in an oblique sagittal plane, and your ultrasound image will look like this. So on the left side of your image is proximal and the right side is distal. From left to right, you're going to see the acetabulum and the femoral head, and in between them is your hyperechoic labrum. Anterior to these structures, you're going to see the hyperechoic contour of the capsule, and then superficial to this would be the anterior hip flexor muscles. So when performing an anterior hip joint injection, the transducer is positioned in an oblique sagittal plane. Obviously, the patient's supine. The interventionalist is on the ipsilateral side of the hip that's being injected, and your needle will go from a lateral to a medial position, and that's going from a distal to a proximal trajectory. So there's two targets for the anterior hip joint. The most common target is the anterior synovial recess. And this is more common because it's easier to perform. It's easier to find this structure, especially if there's an effusion into the joint. You'll see a space where you can insert your needle into. One drawback of this approach to getting into this recess is that there are ligaments called the ligament of Weidbrecht, and this forms the innermost fibers of the capsule, and this can create folds in the femoral neck which can sequester your injectate. So just be careful of that and make sure that your flow goes intra-articularly. The second target is the is the junction of the femoral head and the acetabulum. And because this goes closer to the weight-bearing structures, it's the more preferred injection approach when performing regenerative procedures so that you can get your cells closer to the involved regions. Know that in the trajectory of your needle, there's going to be your lateral circumflex femoral vessels, which is going to be anterior to your femoral head and neck. And so just make sure to put your ultrasound in there, identify these vascular structures, and avoid it as much as possible. Okay, so next structure anteriorly is your iliopsoas muscle and tendon. The iliopsoas complex is composed of your large muscles, your iliacus laterally and your psoas medially. And they form a myotendinous junction right at the level of the superior pubic ramus, but the true iliopsoas tendon doesn't really form not until it goes more distal, and then it inserts into your lesser trochanter. So the probe is positioned in oblique sagittal plane in line with the tendon as it crosses the femoral head, and we'll see it in the next slide. We'll also see in the next slide the iliopsoas bursa, which is located between the anterior joint capsule and the iliopsoas tendon. So that's your iliopsoas complex muscle. Okay, so the probe is positioned in the same way as when we are evaluating the anterior hip joint. It's positioned in an oblique sagittal position, and this will make it parallel to the tendon. And sometimes you might have to move the distal portion of your probe a little bit medially to get to the lesser trochanter. You can do a long axis view, which is on the top part of your screen here, wherein you'll position your needle in plane. If you're doing a procedure or an injection, the needle will be in plane from a proximal to a distal position. But you can also evaluate the iliopsoas muscle and tendon and perform the procedures in a transverse or a short axis orientation, wherein your probe is in an oblique axial plane parallel to the inguinal ligament and the iliopectineal eminence. So if you look at the bottom ultrasound image here, the lateral is on the left side of your screen and the medial is on the right side of your screen. So going from lateral to medial, you've got your anterior inferior iliac spine, and then you have that's showing the iliopsoas tendon as on the top there. So these are your iliacus muscles and the psoas muscles combined. And just under these muscles is your hyperechoic fibrillar tendon, which is pointed by the arrow here, and that is just riding right on top of the iliopectineal eminence. And this would be one way to localize that tendon and also to perform procedures. Note the neurovascular structures, which is located medially. So with the anterior hip, you can also evaluate the iliopsoas bursa. And as mentioned, this is located between the joint capsule and the iliopsoas muscle and tendon. And this can originate starting at the femoral head, and it can extend all the way deep into the iliopsoas tendon. And when draining this bursal fluid, you can either do it in a long axis approach on the top part of your screen here, wherein your needle can be in plane or out of plane, or you can do it in a transverse approach on the bottom side of your screen here, wherein your needle will go from a lateral to a medial direction. And the bursitis is shown by the arrows here on your screen. Try to avoid the neurovascular structures which are medial to the tendon, muscle, and bursa. Okay, so next let's go over the rectus femoris tendon. The rectus femoris has two origins, the direct head, which originates from the anterior inferior iliac spine, or AIIS, and an indirect head, which originates inferior and posterior to this region, which is from the superior acetabular ridge. So this is the direct head, and this is the indirect head of the rectus femoris. And so to visualize the direct head, your ultrasound is in the anterior hip in the sagittal plane, long axis to the direct head of the tendon. And to evaluate the indirect head, you just move the proximal portion of your probe ever so slightly posteriorly and laterally to be in line to that superior acetabular ridge and in plane to the tendon fibers, as shown in the lower right portion of your screen. So make sure not to confuse your AIIS to your ASIS, the anterior superior iliac spine, which is located superiorly to the AIIS, and this is usually a palpable region. But this is where your tensor fascia lata and your sartorius are attached. And so you can see the tensor fascia lata is located laterally and your sartorius muscle is located medially. So if you put your probe transverse to the ASIS, you're going to see the TFL laterally here and your sartorius muscle medially here. And in advanced courses, you'll actually see that on top of that sartorius, just under the inguinal ligament, will be your lateral femoral cutaneous nerve, and you can follow that all the way to the lateral portion of your thigh. Okay, so now let's move to the greater trochanter in your hip. As I mentioned, this is the protuberance in the proximal femur laterally, and it's got three facets or surfaces in the protuberance. If you look at your diagram on the left here, you're gonna put your probe transverse to this region, and that will show these three facets. And so you have the anterior facet, which is where your gluteus minimus tendon attaches. And a little lateral to that will be your lateral facet, and then posteriorly will be your posterior facet. So note the apex, which is where the asterisk is located, and this is the junction between your anterior and lateral facet, and this will form as your home base. So you look for that first to orient yourself, and then you can find the three facets from this origin. Also note that each tendon has its corresponding bursa. So in between the tendon and the cortical surface will be your gluteus minimus bursa, your gluteus medius bursa, and then posteriorly your gluteus maximus bursa. So when they actually talk about trochanteric bursitis, most of the time they refer to the gluteus maximus bursa because this is the largest of the three and the most commonly affected. So when you evaluate the gluteal tendons, the patient will be in the lateral decubitus position with the involved hip up, and your probe will be in a transverse direction into the greater trochanter. So you'll identify the apex first, which is the top of the heel there. If you look at the middle image here, you're going to see right at the center will be the apex where the asterisk is located. And then from then on, you know, the anterior to that will be your anterior facet where your gluteus minimus is attached. Lateral or posterior to that would be your lateral facet where your gluteus medius attaches. And then posterior to that will be your posterior facet where your gluteus maximus attaches. And if you put your probe in a longitudinal axis parallel to each of these facets, you'll see each tendon and its tendon fibers better, and you can evaluate for tendon tears, for tendinosis, and tendinitis. If you put your attention into the gluteus medius picture here on the bottom center of your screen, you'll see that there's another hyperechoic fibrillar structure superficial to the gluteus medius, and this will be your iliotibial band. This is where you'll see the friction syndrome, where in your IT band will kind of rub over the greater trochanter into the gluteus medius. So when performing a procedure, again, the patient is in a lateral decubitus position. Your probe can be positioned either in a sagittal plane or in a transverse axial plane. The advantage of the axial approach is that you can hit multiple tendons in the different facets with just one skin entry. Okay, moving on medially, we are looking at the adductor muscles and tendons. For positioning, the patient is supine, the hip is externally rotated and abducted or abducted. The probe is in a long axis direction to the adductor tendons, as shown by the orange line here. And if you're doing a procedure, the needle will be in plane from a distal to a proximal direction. So when you look at the ultrasound image, the left side, the middle image here is showing a long axis picture of the ultrasound, and it is long axis to the tendons. So your pubic tubercle is PT, and then you'll see from superficial to deep would be your different or your three adductor longus muscles and tendons. You've got your adductor longus superficially, and then adductor brevis, and then your adductor magnus, which is the deepest portion. The right side ultrasound image is the short axis view of the adductor muscles, showing the different muscles with a relatively hypoechoic muscle tissue here with hyperechoic septae, or what they call the styrene pattern, showing normal muscles here. So we're talking about sports hernia. The most common site of injury actually is the aponeurosis that's connecting your adductor longus and your rectus abdominis tendon. So you'll see when you put your ultrasound probe in a sagittal oblique plane, you'll see the common aponeurosis as indicated by the open arrows over the pubis, and this connects your rectus abdominis on the left here, and the adductor musculature on the right, specifically your adductor longus muscle typically. So just note that whenever you're treating these patients, to include that in your treatment protocol. Okay, so moving on to piriformis muscle. So the piriformis syndrome is defined as a compression of the sciatic nerve by your piriformis muscle. This is commonly caused by poor biomechanics, and it creates sciatic nerve irritation and what patients call sciatica. It's actually not very common. It's only found in about 6 to 8% of all sciatica. And this condition presents as a unilateral buttock pain characterized by shooting, burning, or aching all the way down to the back of the leg. Now, the piriformis muscle can be stressed due to poor biomechanics from either prolonged sitting, acute trauma to the gluteal tendon, or when the piriformis is overused, irritated, or inflamed. It can create sciatic nerve irritation. But given the lack of validated diagnostic criteria, piriformis syndrome is actually a diagnosis of exclusion. And there's a wide differential diagnosis on when patients point to their buttock region as the cause of their pain. It's more commonly called the deep gluteal syndrome because most oftentimes it's the other surrounding structures that are actually the cause of the pain rather than the piriformis itself. And so one other structure would be your obturator internus muscle tendon, wherein it gets irritated or injured as it crosses over your the ischial spine here. This is number 2 on your image. Or it could be a posterior gluteal myofascial pain from either a spasm of your quadratus femoris muscle, which is number 3, this rectangular shape muscle, or it could be because of ischiofemoral impingement, wherein the space between your ischium and your femoral head is shortened, thus compressing all these structures, these deep, short external rotator muscles that are impinged in between the space. So when you're doing a piriformis muscle injection, know that there are different variations of where the sciatic nerve is located in relation to the piriformis muscle. Traditionally or more commonly, the sciatic nerve is located inferior into the piriformis muscle, but it can really be anywhere near the muscle. It could be superior to it, intramuscularly, laterally, medially. So just look for that nerve first, identify it, and avoid it when you're trying to perform an intramuscular piriformis injection. So another thing to note is that there are different anatomical variations of the piriformis tendon insertion, and sometimes it actually conjoints with the other tendons of the deep hip external rotator muscles or the gluteal muscles as well. So that's one of the reasons why it's hard to diagnose this condition, and it's hard to find it just in isolation. Okay, so when we are evaluating the piriformis muscle, the patient is either prone or in a lateral decubitus position with the hip internally rotated. So your home base would be putting your probe into the ilium, and the medial portion of your probe is directed superiorly, while the lateral portion of your probe is directed inferiorly, so that you are parallel to the fibers of the piriformis muscle. So you start at the ilium, and the image is shown at the topmost portion here, wherein you will see the ilium as a hyperechoic signal with its characteristic contours as shown here. As you go inferiorly into the sciatic notch, you'll see the ilium divide into 2 lines, and that will be your sacrum medially on the left and your ischium laterally on the right of your screen. And you'll see a space in between these 2 bones, so that will be your sciatic notch. And the first muscle that you see in that sciatic notch as you go down from your position is your piriformis muscle. And so we'll see that better here in the next slide. So you'll see the gluteal muscles on the top, and then as you go down, you'll see the sciatic notch, and then the most inferior picture here, you'll see this hammock-shaped muscle, which is your piriformis muscle, and you'll see the neurovascular structures, specifically the sciatic nerve and some vessels inferior to it. When you're doing a procedure, you'll see on the presentation here on the right, your needle can be either directed laterally or medially, depending on which part of the muscle or tendon you want to inject. So this is a live a video of the gluteal region coming from superior to inferior direction. starting from the gluteal muscles all the way to the piriformis muscles. So I'm gonna play the video, and you're gonna see the gluteal muscles first with the iliac line, and then you'll see the iliac line divide into two lines. And once that two line divides, you'll see the piriformis muscle, which is this hammock shake muscle. I'm internally, externally rotating the hip to show the piriformis muscle. So let's play that again. Again, gluteal muscles, and then you see the sciatic notch here between the two bones, and then finally your piriformis muscle moving here while I'm internally and externally rotating the hip. Okay, so next is your your sacroiliac joint, or your SI joint. Know that this is a diarthroidal joint that has both a fibrous capsule and a synovial portion. The upper 2/3 will be your cartilaginous portion of the joint, and the lower 1/3 is your synovial portion of the joint. SI joint pain makes up about up to 30% of the individuals with low back pain. So it's one of the more common things that we see in clinic. Know that there are a lot of these thick dorsal SI ligaments, superiorly and inferiorly. And in addition to that, there's also other ligaments, namely the sacrotuberous ligaments and the sacrospinous ligaments, that all add stability to the joint. And in fact, when patients are having SI joint dysfunction, it's most commonly due to a problem of the ligamentous dysfunction rather than an SI joint problem. And so when performing an injection of the SI joint, the standard of care still is fluoroscopy using live X-ray to identify the joint. The advantage of this is that you can use the contrast to best visualize the joint and get an arthrogram of it, and also you can confirm the interarticular flow and the vascular uptake. However, ultrasound-guided injections can also be performed. It's easier to perform. There's no radiation. The limitation, obviously, is you can't rule out vascular uptake, and you can't really identify for sure an interarticular flow. So if you're doing an SI joint injection using ultrasound, you're gonna position the probe transversely into the SI joint. The person injecting the joint is positioned on the contralateral side, because you're going to be moving your needle in a medial to lateral direction, as shown in the picture here. For the superior SI, you're going to put your probe in a transverse orientation. You identify the sacral spine medially first, and then as you move your transducer laterally, the first break that you'll see or the bony contour of the sacrum is your sacral foramina, as shown here in the white arrow. And so try to avoid that and don't confuse that as your SI joint. So keep going laterally until you find the intersection of your sacrum with your ilium, and that will be your SI joint. When doing the injection in the inferior portion of the joint, the probe is positioned in the same way. It's going to be transverse into your sacrum. So first you identify your sacral hiatus, move your transducer laterally to identify the edge of the sacrum, and your SI joint will be the intersection of the edge of the lateral edge of your sacrum to the ilium. So this is a live video of your sacral joint. You'll see in the middle of your screen here is your sacrum with the ischial spine in the middle, excuse me. And then you'll see the sacrum with the sacral foramina laterally. And if you keep going laterally, you'll see another indentation of that contour, which will be the SI joint. And you'll know that it's the SI joint because it intersects with your ilium. It's the lateral most portion of your sacrum. All right, and then lastly, we have your proximal hamstring tendons. You've got your three hamstring muscles, semimembranosus, semitendinosus, and your biceps femoris, but then they form two tendons. So the conjoint tendon is the larger of the two, and this is a combination of your biceps femoris tendon and your semitendinosus tendon, and this will be found medially and inferior in the ischial tuberosity. And then the other tendon is your semitendinosus tendon, which will be located laterally and superiorly in the ischial tuberosity. Know that the sciatic nerve is lateral to the tendons, and we'll see that in the next slide here. So those are your hamstring tendon attachment. Okay, so on the left side of your screen is the short axis orientation of your probe. Lateral is left, medial is right. You'll see the conjoint tendon, which is the bigger of the tendons medially. And then lateral to that is your semimembranosus tendon. And then deeper and lateral to that would be your sciatic nerve, as indicated by these letters SN, which is located superficial to the quadratus femoris muscle. So when you're doing an injection, make sure that you're not mistaking your sciatic nerve as one of your proximal hamstring tendons. For diagnostic purposes, if you rotate your probe 90 degrees and go long axis to each of the tendon, you're gonna see in a better detail the tendon attachment and evaluate for tears and tendinosis and bursitis. And that ends my presentation. Thank you so much for your time.